Hi, good morning, everyone. My name is Jesu Tofumi Fajemisi. I'm a PhD student at Moffitt Cancer Center, University of South Florida, and I'll be the host for today's meeting. I'd like to introduce our speaker for today, Dr. Joe Weygand. He has a long-standing interest in the application of medical physics in low and middle income countries. He has a bachelor's degree in physics from Columbia University, a master's degree in medical physics from University of Texas MD Anderson Cancer Center, and a PhD in physics from Heidelberg University in Germany. He serves as the Director of Global Radiation Oncology at Dartmouth and the Program Manager of Therapeutic Medical Physics for the nonprofit organization RAD-8 International. He has been on he has been on global medical physics outreach trips in Tanzania, Senegal, Uganda, Ghana, Mongolia, Malawi, and Nigeria, and has additionally engaged in virtual education initiatives in Kenya, Guyana, the Ukraine, Turkey, South Africa, and Ethiopia. He serves in a variety of capacities on multiple committees and subcommittees on APM's International Council and is a member of the IPO Africa working group, which is currently executing radiotherapy clinical trials in Africa. Thank you so much, Dr. Joe, for all that you do for the low income and middle income countries. And yeah, you have the floor. If you have any question, please take advantage of the chat box and drop your questions as the lecture goes on. Thank you so much.
Yeah. Thank you for the introduction, Fumi. Welcome everyone. So today we're going to be talking about a topic that is quite important, especially in LMICs, where a lot of clinics are transitioning from the more conventional three-dimensional techniques to the more advanced techniques of intensity modulated radiotherapy and volumetric modulated arc therapy, IMRT and VMAT. So today we're going to be talking about one aspect of that transition that is reasonably important, namely the commissioning of IMRT and VMAT. So yeah, the idea is that in these techniques, IMRT and VMAT, we're able to achieve an increased level of dose conformality, which then leads to decreased toxicity without compromising control. And the way that we do this is with the sort of application of these additional collimators that are known as multi-leaf collimators that are many different individual collimators that are sort of very thick in one direction, the direction of the beam, but very thin in the other direction, which allows you to then shape them in really any shape that you want, which then allows you to have a high level of conformality to the tumor. So multi-leaf collimators are made of a tungsten alloy. So typically, at least on the linear accelerators that I'm used to working with, varying linear accelerators, there are 120 leaves. These are 60 pairs on either side. Um, the linear accelerators at my facility are all singly focused, which implies that they have a rounded leaf end. But there are certain linear accelerators out on the market that are known as doubly focused, which have a sort of straightened leaf end, but then they move in a more arc-like manner where the singly focused rounded leaf ends move sort of in and out. Um, so most of the linear accelerators at my facility have conventional MLCs where the inner 20 centimeters are uh, zero point 0.5 centimeter thickness, and then the outer 20 centimeters, the leaves are 1 centimeter thickness. However, if you are sort of starting a stereotactic radiotherapy program, you'll probably want a linear accelerator with high definition MLCs. And these you have a smaller MLC carriage. Um, However, the inner 8 centimeters are only a quarter of a centimeter in thickness. So So you're able to get more of a conformal shape in your target. And then the outer 14 centimeters are a half of a centimeter. So a lot of the development of IMRT. So firstly, MLCs were developed, and this was done in the 80s and the 90s. Most of it was spearheaded by Anders Brom at Karolinska Institute in Stockholm, Sweden. Then in about the mid 90s at the Deutsches Krebsforschungszentrum in Heidelberg, Germany, IMRT was developed by Bortfield, where essentially he utilized the MLCs that were already available, but then he sort of created the inverse planning paradigm where instead of sort of creating a radiation treatment plan in a forward way, so defining the gantry parameters and the collimator parameters and the couch parameters, all of this. Instead, you basically tell the machine exactly what you want to achieve dosimetrically, and then the machine comes up with an inverse solution to find the most optimal way to achieve those goals. And we had a previous talk on inverse planning algorithms about a year and a half to 2 years ago by Noah Bice. So you can look on the YouTube channel if you want to know more about that. But then also one of the early adopters of IMRT was the Royal Marsden Hospital in London. So really, all of the heavy lifting in the development of IMRT was done on the European continent. So what is the commissioning of IMRT, right? In medical physics, we use the word commissioning to mean a lot of different things in different scenarios. So it's always good to specify in the beginning whenever you're talking about commissioning what exactly you're talking about. Um, and in the context of IMRT, it means the initial verification via phantom experiments that the treatments can be planned, prepared, and delivered with sufficient accuracy. And we'll basically be sort of going into each component of that as we go through the talk. So the sort of typical document that you would want to look at is the American Association of Physicists and Medicine, TG 119. It was published in 2009, which was a little bit after IMRT was developed, but really once IMRT was pretty isotropically implemented into clinics, at least in the developed world. So they came out with this document that is a little bit uh, different than most APM task groups. Most APM task groups are sort of just like recommendations and sort of descriptions of systems, where this kind of reads a little bit more like a research paper for an APM task group. But it kind of all the same gives the prescription of what exactly one is supposed to do to commission your IMRT system. So basically, in a nutshell, there's four things that you have to do. Basically, you want to define the target and normal structure shapes on CT images of the dosimetry phantom that you're going to be using for your measurement. We'll talk more about what that phantom can be, but basically you just have to take a CT of the phantom and then define the target, define the normal structure, some mock targets, mock normal structures. TG119 provides sort of structure sets that you can use, but really you could create your own. Really the idea is that you just want to make sure that it is a kind of clinically relevant plan and that you are sort of pushing your MLC system and your MLC model to the limits. Um, but yeah, basically it's much easier to just use the TG119 plans that are provided because you can just download them off of the website. Um, you then plan a treatment plan using IMRT, or if we're talking about VMAT later in the talk, using VMAT. You then deliver the treatment with a measurement device, whether it's an array detector or some number of point detectors. And then the idea is that you want to compare the dose that you measure in the phantom during the delivery to the planned dose at that same point in the TPS. And you can do this, like I said, either comparing um, point doses, or you could do this in a sort of a array manner where you actually perform gamma analysis on this. So in TG119, they had a number of institutions, around 10, with a variety of different accelerator systems, both Varian, Electa. At the time, there were Siemens accelerators and tomotherapy as well. A number of different delivery techniques, whether dynamic or static, and then a number of different treatment planning systems, just so that this study was not biased in the direction of a single vendor. They came up with a pretty broad array of different accelerator delivery techniques and planning systems. So they talk about the idea of a confidence limit. So the confidence limit is a sort of statistical concept where you can kind of look at the degree of achievement that should be expected. Basically, it assumes a normal distribution of possible measurements, and that 95% of measured points will fall within a confidence limit. That's how they define the confidence limit. It's defined by the formula above, and as you can see, it combines the influence of systematic and random differences. And yeah, basically it's an idea, right? Because the idea was that a priori, right? You don't know what you would expect when you are taking these measurements, right? How good is good, and that is always kind of a question when we are actually performing the IMRT QA, right? The APM says obviously that 95% is our limit, and then 90% is the action limit. But really, where do these numbers come from? And the idea is that uh, they take a large statistical sample, and then looking at the standard deviation of that sample, they can then kind of estimate what level of achievement should be expected. So if you get a measurement that is outside of this confidence limit, that is when you should be then alerted. So the measurements should be done in a phantom. The phantoms should permit point dose measurements and a planar dose distribution done in the coronal plane. I'll show you a picture of the phantom that we used a little bit later, but really it doesn't matter, right? As long as you have solid water, and uh, you can take point dose measurements, and then that you can stack a piece of film, chromic film, to measure a planar dose distribution. That will be sufficient. Um, they recommend that the ion chambers be smaller than Farmer chambers, such as the 0.125 cc scanning chamber. This is because when we are making measurements for IMRT, right, often we are using small fields, so we can be in the realm of small field dosimetry, which, again, if you want to go deeper into small field dosimetry, we had a talk on that about 2 years ago as well that you could find on the YouTube channel. But yeah, basically you would want to use a detector that is congruent with the demands of small field dosimetry. Um, it's best if you have two detectors. You don't have to. You would just have to take twice as long in doing your measurement, moving the detector each time. But basically, it's more efficient if you have two detectors, and you place one in the position of the pseudo target, and then one in the position of the mock OAR. And then like I said, at least one film placed in a coronal plane. So this is a Phantom that we used. I have no idea where we got it. It looks super old. Basically, it just has a number of uh, sort of inserts where you could place a ionization chamber. And then there is a sort of cartridge in the back where you could put a piece of film. But yeah, it doesn't, you don't have to have a specific Phantom just for this. You can do all of this with just regular solid water and stacking film with the solid water. So this is the piece of equipment that we use, but this is just one example. It's really, there's many ways to skin a cat. So when they talk about TG119, they talk about six specific plans of sort of increasing levels of complexity that kind of allow you to characterize how good your system is. And when we talk about how good your system is, right, uh, the accuracy of your dose calculation in your treatment planning system will depend on your MLC model, right? So the various parameters, and this depends again on which vendor you use, whether it's Varian or Electa or another TPS. How they actually create the model, but basically just the physical parameters of the MLC leaves you need to model so that you can actually accurately calculate dose. With variant systems, the main parameter that you need to measure is the dosimetric leaf gap, which can be thought of as essentially right. Remember that your leaves are rounded, so even when they're completely closed, there is a level of sort of inter-end leakage that gets through. Um, so the the dosimetric leaf gap can be thought of as basically how far into itself you would have to push the leaves such that the leakage goes to zero. Um, then there's also other parameters such as the transmission through the leaves, et cetera, et cetera. But basically, we are testing your MLC model, right? Your MLC model allows you to accurately calculate dose on an IMRT or VMAT, any modulated plan. So we're going to start with very simple plans that at first don't even use the MLCs, like an APPA plan. Then we start to increase in levels of a complexity where we have a plan that is essentially a band plan. We'll go into each of these plans in the subsequent slides. Then we will have a multi-target plan. Then we start to have some sort of anatomically motivated plans, a prostate plan, a head and neck plan, and then a pair of C-shaped plans. So we'll go into each of those one by one. Yeah, so the APPA plan is essentially a 10 by 10 square field defined by the jaws where we deliver 200 centigrade of mid-plane, the central axis point dose to kind of calibrate the chamber reading for subsequent tests, and the gamma analysis for film in the central plane. And the idea is, right, before we start really pushing our system to the limits with very modulated IMRT plans, right? We want to be able to have a baseline idea how our treatment planning system calculates dose, how accurately it calculates dose, right? So we start with a very simple, just APPA or lateral type plan, right? So the idea is that we can then see what the baseline agreement between the TPS and the measurement is. So then, as we start to increase the levels of a complexity, we can start to see where our MLC model starts to fail. But so we start with very simple plans. First one has nothing to do even with the MLCs. Second one, you start to add a level of complexity, and now you have series of bands where you have certain thicknesses that each get a slightly different dose. It's kind of like a stepwise function. Dose as a function of lateral distance, as you can see in the figure in the bottom right. These fields are now defined with the MLCs. They're still not IMRT, but now we're defining the fields with the MLCs. So then we start to look in we're adding a level of complexity. So here, like I said, it's a series of APPA MLC defined fields using either the joules or the static MLCs. It's a set of 5 bands, each of which are 3 centimeters wide, receiving doses from 200 to 40 centigrade in kind of even increments. We then measure the central axis point dose, and we can perform gamma analysis for film in the central plane. Okay, now we start to increase the level of complexity again. And here we actually have an IMRT plan. This is a multi-target plan. So you have these 3 stacked cylindrical targets, each of which are supposed to get a different dose. You can kind of see in the table, the central target is supposed to get 50 gray. The superior target is supposed to get 25 gray, and the inferior target is supposed to get 12 and a half gray. Yeah, each target, like I said, is 4 centimeter diameter, 4 centimeter height. They're cylinders. We then create the plan. At least in TG119, they created these plans using 7 6MV fields, each at 50-degree intervals. But really, you would just want to do this in a way that is congruent with how you actually treat, right? So if you always use 9 field static or dynamic MLC IMRT, then you would want to use 9 fields. But just to standardize it, they kept all of these at 7 fields. Like usual, they measured a point dose at the center of each target and then film at mid phantom. Okay, now we're moving on to the anatomically motivated plans. The this one is a mock prostate plan. And essentially you have a uh, prostate CTV, which is an ellipse. The PTV is then a 6 millimeter expansion on top of the CTV. The rectum is then a cylinder, and to kind of mock real planning situations, you have an intersection between the organ at risk and the PTV, and essentially 1/3 of the rectum intersects with the PTV. So we're really starting to push our system to challenging levels of plans where that actually are representative of how actual clinical plans can go. And then you also have a bladder target that is also an ellipse. They plan these with 7 6MV fields at 50-degree intervals, took the point dose at the mid PTV and at the mid rectum, right? So if you remember back to that phantom that you saw, that we used, that had that sort of array of inserts where we could put the chamber in many different places. So we would put the one chamber in a point that corresponds to the middle in this case, because the PTV is right in the middle of the phantom. And then the rectum would just be a little bit inferior of that. You could actually measure and see how inferior, but probably it would be in the insert directly below the PTV. And then the film at mid phantom, like usual. And again, increasing levels of complexity. So now head and neck plans, which oftentimes really start to push the limits of our MLC model, um, that and levels of complexity in just clinical planning. So basically, here you have this pretty large head and neck PTV. You have 2 parotids on either side, kind of like tucked into the PTV. You can see in the figure in the top left, and then you have a spinal cord. Um, and I should have mentioned in both times, right? They specify what the sort of clinical goals of the organs at risk should be, right? So for the PTV in this case should get 50 gray, the cord not more than 40 gray, and then the parotids less than 20 gray, which as you can see is pretty challenging because the PTV itself is getting 50 gray and it abuts the parotids. But that's can be a realistic situation. Here they used 9 6 MV fields at 40-degree intervals. They took a midpoint dose, mid PTV, and then film at mid phantom through the parotids and through the cord. And then the last pair of plans that they talk about in TG119 is a C-shaped plan. So basically, this is not anatomically motivated, but it's designed to really push your system to the limits. And the idea is that there are two versions of this plan. So in both cases, the PTV is supposed to get 50 gray, but then in the easier case, the core, the organ at risk core that's in the center, is supposed to get 25 gray. And then in the harder version of it, again, the PTV is supposed to get 50 gray, but then the inner core is supposed to only get 10 gray. Here they also use 6 MV fields at 40-degree intervals. They measured point dose at the PTV and in the central core, the organ at risk, and then film at mid phantom and mid PTV. And then this kind of describes the what was achieved at the number of institutions. So basically this mean that they are showing is kind of the percent difference. It's defined up in that formula in the top left, right? It's the difference between the measured and the plan divided by what is expected. And yeah, so as you can see, uh, they had pretty low mean differences except in the head and neck plan. And this shows the differences for each the average in each plan, and then the bottom table shows averaged over each institution. So obviously there is sort of inter-institutional difference between how good their MLC models are. Same, they report the results in the OARs a little bit higher than the results in the targets, but on the same order of magnitude. So then you could ask the question, okay, a lot of what we do today is VMAT, right? So what do you do for VMAT? And luckily, a few years later, they came out with a paper. It's not a AAPM task group, but it was basically a research study that is the application of AAPM TG119 to VMAT. So it basically kind of recapitulates the exact same thing that was done in the IMRT setting, but it does it now for a VMAT delivery. The study design was they wanted to determine VMAT is capable of delivering plans of comparable quality as IMRT plans using TG119 as a metric. So they kind of wanted to compare IMRT to VMAT. Here for the IMRT measurement, they always use 9 static gantry DMLC IMRT fields at 40 degree spacing. And then for the VMAT ones, they would always use 2 VMAT arcs, as shown here. And yeah, these are the results that they found. The dosimetry between IMRT and VMAT was quite comparable. We'll see the DVHs on a later slide. But here, so these are for the prostate plan, the multi-target plan. Here's for the head and neck plan, and then the C-shaped plan. These are the dose distributions as you would expect, right? VMAT has kind of that smoother dosimetric distribution. IMRT has the more uh, star-like dose distribution, where you have sort of high dose smears coming from the directions that the gantry is actually delivering from. And yeah, these are the deviations. So as you can see, in most instances, VMAT performs marginally better than IMRT, but just by a little. Like each time, the two organs at risk, the VMAT rectum and the VMAT bladder, are both a little bit down and to the left relative to the IMRT rectum and IMRT bladder. Same thing with the parotids and the head and neck plan. Also, you have a little bit better sort of coverage DVH. If you look at this head and neck, uh, the blue is the VMAT, and as you can see, you come a little bit uh, more of your dose gets 100%. Here's for the C-shaped plans and the multi-target. So kind of the same trend holds in each. Basically, that you have comparable dosimetry with VMAT and IMRT, maybe a little bit better than VMAT, um, but not by much. They also measured other metrics like conformity index, homogeneity index, and then also performed gamma analysis. Again, in each instance, the symmetry between IMRT and VMAT was pretty similar. So basically, they showed that IMRT and VMAT showed similar results for all four of the test cases. The major difference, one of the major differences, is that VMAT was 2 times more MU efficient. So that means that to produce a comparable dose distribution on these complex plans, such as the head and neck plan or the hard C-shaped plan, IMRT requires almost 2 times more MUs than VMAT does. Um, Also, just from a practical perspective, VMAT allows you to treat the patients a little bit more quickly just because of the nature of VMAT and that it's delivering while the gantry is rotating. So it allows you to actually deliver the entirety of the MUs in a little bit more efficient, quicker amount of time. Because I would say more so because of the efficiency than the dosimetric benefits. We use VMAT significantly more than we use IMRT in my clinic. Very rarely do we use IMRT on our standard linear accelerators. Um, the one counter example to that is we use my clinic, we have an MR guided radiation therapy linear accelerator. So in that case, the delivery is pretty much always step and shoot IMRT. And that is because when you're actually, and we'll have a lecture on MR guided radiotherapy in a couple of months. But basically, the idea is that you're acquiring real time MR images to make sure that the tumor is where it's supposed to be. And actually, the gantry is a giant piece of electronic equipment. So when the gantry is rotating in as it would in a VMAT delivery, the MR images that you're acquiring are distorted because of giant eddy currents that are produced. So actually the images become then not useful. So the delivery has to be kind of a step and shoot static field IMRT delivery with MR Linux. However, on our conventional Linux, pretty much all of our IMRT patients are VMAT and not static IMRT. There's another document that probably warrants a little bit of discussion. This is MPPG 5A. It came out about 10 years ago. Um, it mainly focuses on the commissioning of treatment planning systems, which, right, when we're talking about the commissioning of IMRT and VMAT, right, we were talking about comparing the measured dose to the treatment planning dose. So obviously the commissioning of your treatment planning dose is of utmost importance in your sort of VMAT or IMRT delivery accuracy. Um, so here they talk about a number of phantoms that can be used. Um, they talk about a number of tests that should be done if you are commissioning your treatment planning system. It's kind of outside the scope of this talk to really go deep into this, but I refer you to the document MPPG 5A. And as you can see, though, TG119 tests are one critical component of your treatment planning system commissioning. A few important recommendations that they make that also holds for our TG119 tests that we have been talking about all along. So the range of optimization parameters, namely the amount of modulation, the minimum field size, and the types of plans that you use clinically during commissioning should be clearly documented and representative of clinical practice, right? You don't want to be treating with these super modulated plans when you commission these kind of easy low level modulation plans. They also say that in general, more time should be devoted to fine tuning the model for the highly modulated plans. Simple plans are typically much less influenced by the often changed parameters, particularly the parameters related to your MLC model. And this actually we see all the time when we run IMRT-QA, right? Which plans are typically problematic when we're running IMRT-QA. It's the plans that are overly modulated, right? And that is because as your level of modulation increases, the the deviance between your MLC model and the actual physical properties of the MLC sort of become amplified when you have higher levels of modulation. So if you have a bad MLC model, you might not see it if you're delivering a plan with a IMRT factor of 2, but maybe if you're delivering a plan of an IMRT factor of 6, you'd fail the QA. So these sort of differences or inaccuracies in your MLC model become amplified as the level of complexity of the plan increases. They also recommend evaluation criteria. Uh, so basically, kind of what we did in a way, the ion chamber measurements, the planar volumetric array measurements, and then also they recommend an end-to-end test in their treatment planning system commissioning. So I was involved in the commissioning of IMRT and VMAT when we got a new linear accelerator. So what did we actually do? So we actually used the TG119 plans. Like I said, you can actually go on the website. You can just Google TG119 test plans and you get located to a page and you can actually just download those structure sets. And also the MPPG 5A, which they also call TG44, also has additional test plans. So we used a combination of the TG119 test plans and the TG244 or MPPG 5A test plans. And both of those you can download from an AAPM website. So the plans that we actually used was the C-shaped TG119 plan. We delivered it with a DMLC delivery and a VMAT delivery. You can kind of see the dose distribution in each case. We did an abdominal plan that came from TG244. We did an anal plan that came from TG244, and the anal plan actually is quite difficult in what it tries to dosimetrically achieve. So this one really pushes your MLC model to its limits. We have an additional head and neck plan from TG244. We have an additional prostate plan from TG244. And yeah, the measurements, like we showed the phantom earlier. So we have this cube phantom. I don't really know what to call it, so I just call it a cube phantom. But basically, it's a cubic slab of solid water with looks like 25 different inserts where you can actually insert the detectors. We did this for each energy that we might treat, 6X, 6 triple F, 10X, and 15X, although there are controversial topic, but a lot of people recommend that you don't treat IMRT and VMAT using 15X due to the neutrons that are produced. But we measured it just to be comprehensive. Um, and also uh, so we would always measure on the central axis and on an avoidance structure. So we would always want to put one ion chamber in the target, one ion chamber in the avoidance structure, depending on the plan, the geometry of the structure set in the plan that we planned on, right? That determines where in the phantom we want to put the ion chamber. We then obviously measure the dose in the treatment planning system, then measure the dose on the ion chamber, and we compare the two. And we would always have a 3% tolerance. So these are just some results. We each plan, as you can see, 0.3% off, 1.2% off, negative 0.1% off, 0.9% off. So each time we got within that 3% tolerance that we tried to achieve. We then we had Sun Nuclear software that allowed for a second check. We performed this sort of secondary dose calculation, and which kind of performs a gamma analysis, and we compared them as well. This is a little bit less important because it's not actually comparing to an actual measurement. But then also what we did is we use an R-check phantom, which is a cylindrical array phantom made by Sun Nuclear. And here we actually were able to compare an array of points in the treatment planning system relative to the measurement in the R-check. And since we have an array of points, we're able to actually perform gamma analysis, and in many instances, we would use this device for our IMRT QA. So this is a summary. All of our measurements were less than 3%. I should mention that in this IMRT QA, our clinic always used 3 millimeter 2%. Sorry, 3% 2 millimeters, because that is the criteria that we typically use in our IMRT QA. But in the gamma analysis that was applied in TG119, I believe they used 3% 3 millimeters as their gamma criteria with a 10% threshold. Yeah, so in summary, there are various guidance documents in the literature. So I hope that this talk provided a reasonably concise uh, uh, discussion of these various documents and summary of these various documents, and kind of a what you should do if you are commissioning an IMRT or VMAT system, right? There's the TG119, there's the application of TG119 to VMAT, and then there's the MPPG5A. We took a variety of measurements in different plans, both point dose measurements and gamma analysis in an array phantom. Um, and yeah, I utilized a number of references in putting this talk together. And with that, I will take any questions that you guys might have. And thank you guys for your attention.
Thank you so much, Dr. Joe, for that wonderful lecture.